So VQ mismatch. Okay, so the V stands for, does anybody know? Ventilation. Okay, so ventilation, so that's our air movement, right? Just the air, okay? The Q stands for?
Is it perfusion?
Perfusion. So now we're talking about the capillaries that are all around those alveoli, okay? So that's perfusion. So, something is happening to where these two, usually like me and you and I, we have plenty of perfusion and we have plenty of ventilation, nothing's impeding any of that. So we don't have a VQ mismatch. Our VQ is good, okay? It's probably normal, which we call 0.8, which we'll get into later down the road, okay? So, if something is impeding either ventilation or perfusion, we're gonna use this fun little line to kind of identify where it's at, okay? Now, we're not doing math, nothing to do with that, so don't get stressed out about that. It's just really thinking about what's happening in the lung and identifying if it's a shunt or if it's dead space, okay? So, when we talk about a shunt, does anybody know what I'm talking about when I say a shunt? And when I'm pertaining to this? Yeah, typically you're right. So it's shunting from one place to the other. Okay. So when we have someone that has is having impedance of whether it be ventilation, perfusion, it does tend to actually shunt, right? So in this case, I really want you to think about, that's where the term comes from, but when you think about shunt, I want you to think about it's shunting ventilation away because it isn't able to get to the capillaries. So here is a picture of a shunt, okay? So this is an alveoli, and this is fluid consolidation, any of that stuff, okay? So, do you think I have an impedance of ventilation, or is this gonna be something where I have a decrease in perfusion across that membrane? It's okay. So what's that?
I was just saying, I would think it increase to see open.
Increase in what, sorry?
And you said increase in the perfusion, right?
Well, it would be either, okay, so we'll just go into it. So in this case, our ventilation's not the issue, right? We're getting ventilation. But what isn't gonna be able to happen is this is a barrier between our capillary here and any of that ventilation that's happening. So we have plenty of ventilation, but our perfusion is not going to be, wait, hold on, flip it around. I'm so sorry. Okay, stop it. Okay, so our perfusion is fine because our capillary vessel is open. I apologize, my brain was flipped. Our ventilation isn't able to reach our capillary. Do you see why? There's something impeding it. This can be fluid. This can be secretions. Anything, some kind of consolidation, okay? So, when you look at this, we have plenty of perfusion, but we have less ventilation because it's being stopped by whatever this is, okay? You can also have this drawn like that, okay? This could be what, atelectasis? We have ventilation coming through, but it's not gonna be able to get all the way through because this is all collapsed. But our capillary is just fine. It's perfusing. Does that make sense? I'm not through the concept yet, but does that make sense? Do you see the picture why we would have more perfusion versus ventilation?
Because there's something blocking?
Yes,
it? Okay.
Something's blocking the ventilation. Now, if I were talking about perfusion, something would be blocking perfusion, and then we wouldn't be able to get through, okay? But we're not talking about that. Shunt is talking about blocking our ventilation. So, in our shunt, we have more perfusion than ventilation. Okay? And if it's a complete shunt, Because we can have a little bit of shunt and we can have a true shunt. If it's a true shunt, we have no ventilation. So no ventilation at all. Okay? So this is all talking about shunt. So when we talk about VQ mismatch, the shunt part is we have more perfusion, right, than this ventilation. Okay? Okay. So on this timeline or graph or whatever you want to call this, does anybody know, have you guys seen this yet? Okay. So normal, usually us, is right here at 8. Why aren't we even with like, this is going to be 1, okay? Why aren't we right in the middle? Like, you know, usually our pH, we want it right in the middle, everything looks good, that's like our normal zone. Why do you think we have a little bit of, are a little bit off? When you talk about ventilation, do we have areas in our lungs where we don't have perfusion? Yeah, what is that called? Anatomical dead space. Anatomical dead space. So we have more ventilation than perfusion, right? That's what dead space is. You have more ventilation than perfusion, okay? So this was shunt, dead space. So it depends on if it's a true or and we'll talk about that, but more ventilation than perfusion. Okay. So this is normal because we have some of the anatomical dead space. Down here at 0, this is a true shunt. Okay. Less than 1, which that's a greater than sign, less than 1 is a shunt effect. So not completely occluded in some way. So it's like just a little bit of a shunt. And I'll give you examples of what the disease process will be like, okay? This is our normal, okay? And then we get into our dead space, which is on this side, okay? So we have true dead space. And dead space effect. Okay, so on this side, we have more perfusion versus ventilation. Okay, on this side, we have more ventilation than perfusion. Okay.
What did you put that 1 next to the shunt effect? What is that for? Just because it's normal?
Shunt effect. Where?
Right on the line.
This right here?
Yeah.
This is just normal. I was just kind of saying it. Yeah, so this is normal.
Okay.
Sorry. Okay, so this is just how the scale is. We have 1 in the middle. Our normal is 0.8. So do you guys remember when you use 0.8? When does that come into effect? Do you guys remember? It's in an equation. Yes, that's our respiratory quotient. So that's when that's where our normal is. So that's when we actually are using this number, our VQ, I guess, normal value. So that can actually change in a patient that has some of these disease processes we're going to talk about. But we always just use normal, okay? So that's where that 0.8 comes from, is right here, okay? That's why that's normal. So if it's anything less than 1, it would be a shunt effect. If it's a true shunt, it's 0, okay? So when we're talking about our dead space to our shunt, we are looking at how much of our perfusion to our ventilation. So we have 0 ventilation during a true shunt, okay? We have less than 1 if it's a shunt effect. So then when we go over on the other side, greater than 1 is considered to be dead space effect. And we do the infinity sign to be true dead space. So infinite, okay? I know, you guys are like, what? Yes, so this is just, I mean, when it comes to, math, we'll look at cardiac output, to our overall, like perfusion and dead space, but we're not doing any kind of real math. I'll show you like how you get to calculate the normal, but I don't have you guys really calculating it too much, and if it is, it's very simple, just division. So, but we'll talk about that. Okay, so, when I talked about dead space, right? We have more ventilation than perfusion. So where's the issue? Is it in the alveoli or is it in the capillary? We have more ventilation than perfusion. Capillary, okay? So for some reason, our perfusion has decreased, okay? So that can be from, what would this be if there's a clot in the lung? Yes, what do we call that? A pulmonary embolism, okay? So that is considered a dead space, a true dead space. That's pretty much one of the only ones. We do have an anatomical true dead space. So PE, pulmonary embolism. Okay. We could also have, do you guys remember emphysema? What, if you have a severe case of emphysema, what does it destroy? You have a decreased amount of what?
The alveolar sac. No.
Say it again.
The alveolar sacs.
Yes, so the destruction of the alveolar wall, right? So usually we have these beautiful clusters, right? All throughout those alveolar, through our alveoli. Well, what starts to happen is these clusters start to kind of just become one big ball, right? So remember, we got rid of all that surface area. So what's all around this alveoli right here? On all sides, what do we have going on there? On the outside? Capillaries?
Mm-hmm.
Capillaries? Because that's where our gas exchange is taking place. So on the outside of these is our capillaries. On the inside is all of our air, ventilation, oxygen, whatnot, okay? So when we destroy a side of this, we not only got rid of that alveolar wall, we got rid of our surface area where gas exchange can take place. That's why over time, this is kind of happening to all those alveoli. They start to have a really hard time with oxygenation, right? And shortness of breath, because they've not only lost those alveolar walls, they've lost the capillaries where gas exchange took place, okay? So if you start to decrease that, are you decreasing perfusion to the lung? Yeah, that was our road, right? So when we talk about dead space, I want you to think of emphysema and blebs and bullae. You kind of remember those a little bit? Okay, so when I talk about dead space effect, I'm gonna say emphysema, blebs, bullae. Okay? The problem's not necessarily with ventilation, it's with the perfusion, right? Okay. So let's talk about shunt effect now. So this is what you need to know for dead space. Okay? There's not a whole lot over there, okay? I mean, you could get into like blood loss and things like that, but these are the main disease processes that we see, okay? That would be considered a dead space issue, okay? So when we talk about shunt, what would be considered a true shunt? And again, this can really go either way. We just kind of make it an all or nothing, because you can have pneumonia but not impact every single alveoli, right? But we just kind of say all or nothing. So what would be something that a disease process that has fluid or secretions? Who can tell me? Pneumonia. I'm just gonna say PNA. What else? CHF, congestive heart failure. So let's get even more specific there. So CHF, what does it lead to? Why CHF, if that makes sense? It's a backup of fluid in the lungs, right? Mm-hmm. What do we call that?
Pulmonary.
Pulmonary edema. So pulmonary edema. Okay. Let's think of some other things. It can be atelectasis. Okay, so things along those terms, right? Something that's going to cause consolidation, block that ventilation from getting to our capillaries and have that gas exchange take place. That is going to be our true shunt, okay? So a shunt effect is gonna be something that's not quite shunting it completely, I guess. So that can be like bronchospasms. Okay, spasms. Okay. So like asthma, you can put down too. Those are really the main two, because all the other ones we kind of deem as being a true shunt. And I'll have some more examples in the lecture, but just to kind of give you guys a brief, we're gonna go through all this again. I just kind of wanted to go through this first so it's not super confusing right out of the gate, although I know it already is. So when we talk about shunt, we're saying that we have perfusion with less ventilation. So how I would word a true shunt is I have perfusion with no ventilation. That's how I'm going to word my true shunt. So perfusion without or with no ventilation. So ingrain that in your brain. That is a true shunt. We have no ventilation. It's completely consolidated to where there is no gas exchange, no ventilation getting through. We call that a true shunt. So our shunt effect, we have perfusion, and there's a few ways you can say this, okay? Perfusion in excess, meaning more, or perfusion, more perfusion than ventilation, But ultimately, it means all the same thing, right? That looks awful, but I have a couple of different ways it can be worded, and so in the lecture, you'll definitely see it, okay? Point 8 is normal. We just say normal, okay? So now we're talking about dead space. So if that one is, if true shunt is perfusion without ventilation, what do you think true dead space is then?
Ventilation without perfusion.
Thank you. Ventilation without perfusion. Without perfusion. In excess of ventilation is what? Sorry. What? You?
No, I wasn't.
Okay. So then what would dead space effect be? Ventilation in excess of perfusion, right? Because we have more ventilation than perfusion. Clear as mud?
Yeah.
Now we're gonna go through the lecture. This is just a like intro to this, and I know it's a lot. And the good news is I'll cover it, Dr. Krager will cover it, you guys will, this will be something that we're gonna go through forever. God bless you. Okay,